Dr. Michael Miller, and I am the new staff vascular surgeon here at Cullman Regional Medical Center. And although I'm not new to vascular surgery, the practice of vascular surgery here at Cullman as a continuous presence is a new practice. So I wanted to start off today just by introducing myself and the vascular practice to the community and let you know a little bit about myself and what we do as vascular surgeons. So to start with, myself, I'm actually from one of your biggest competitors, Georgia. I'm a Georgia boy. I was born in Georgia. I was raised in Macon, Georgia, and after finishing high school, I joined the Marine Corps, did 4 years active duty in the Marines. After that, I decided, well, I may not want to do this forever, so I went back to college and completed both my undergraduate and my medical school training at Mercer University there in Macon, Georgia. I did my medical school training under a Air Force scholarship. So on completing medical school, I started general surgery training at Keesler Air Force Base in Biloxi, Mississippi. I finished that up in 2002 and had the pleasure of serving as a staff general surgeon in Osan, Korea for a year before starting my fellowship training in vascular surgery at the University of Arizona in Tucson. I did do a full 2-year vascular fellowship with both open and endovascular technique training. I'm board certified. After completing my vascular training, I went back active duty with the Air Force and remained on active duty until I retired in 2014, serving at Eglin Air Force Base in Fort Walton Beach Medical Center. I did, during my 10 years at Eglin, I did 2 tours of duty in Iraq, in Operation Iraqi Freedom. I did 2 tours of duty in Afghanistan at Bagram with Operation Enduring Freedom. After I got out of the Air Force, I did stay on the coast for a while and then moved a little bit further north, not much, to Dothan. I was in Dothan for a couple of years before the opportunity to serve the community here in Cullman was available. So what is it that I do as a vascular surgeon? And basically what we like to say is that your hearts and minds belong to somebody else, but we take care of everything else. So basically I do nothing intracranial. I don't crack the chest and work on the heart. That's a cardiovascular surgeon. But as one of my mentors once told me, you're nothing but a glorified plumber. So we take care of all the plumbing. We take care of the blood vessels, whether they're going away from the heart to deliver oxygen-rich blood to the tissues, or the veins that bring the blood back to the heart to be reoxygenated. So what is it with the blood vessels that we work on? So the primary disease that we see in the arteries, those are the vessels that carry the blood away from the heart. The primary disease that we deal with is atherosclerosis, or as people say, is hardening of the arteries. I wanted to give you this slide because I wanted to point something out, is that a lot of people think that plaque actually develops on the inside of the blood vessel here in the lumen where the blood flows, where actually it does not. There are 3 layers to the vessel wall. The inner layer is a thin layer that allows the blood to flow smoothly. The middle layer is a more muscular layer, and then the outer layer is a tough fibrous sheath that sort of holds everything together and protects it. The plaque actually develops in this layer between the inner layer and the muscle layer, and it will penetrate into this muscle layer some. And most of this is lipid, a lot of lipids. There's calcification many times, and cells from your immune system, because your immune system knows that this stuff isn't supposed to be there. So what happens when you start developing these plaques? Well, if you live a relatively healthy lifestyle, you have few risk factors, which we're going to talk about, your vessel stays nice and wide open here. But if you start getting a plaque, it can go several different ways. And these early plaques in the United States are in Western diets. Autopsies have been done on children as young as 4 years old and have found what we call fatty streaks, which are just lipid-laden streaks in the wall of the blood vessel. That's the beginning of atheromatous plaque in children as young as 4 years old. But if it continues to grow, it can start impinging on the lumen of the vessel. If it stabilizes, it's going to have a thick cap, a fibrous cap over it, which is a more safe plaque. But if it continues to get worse and worse, you don't control your risk factors, you're a smoker, you have a lot of these other things, that plaque can continue to grow. And what that does is it thins out that plaque, or thins out that cap over the top of the plaque. And what can happen is it can rupture or ulcerate. And if that happens, then the stuff that is in that plaque can embolize or go downstream, or that injury will be recognized and platelets will stick there and a clot will form, and then that clot can go downstream. So that's what causes big problems, because if that plaque is in your carotid, downstream for the carotid is your brain. So this is the cause of a lot of strokes. And same thing in the coronary vessels. This is the cause of a lot of heart attacks. So that's what can happen in these plaques, and that's why they're such a problem and why we have to fix those things. So what causes these plaques to develop? Well, as a vascular surgeon, I always go over with my patients the big four. I call them smoking, diabetes, high blood pressure, high cholesterol. Age affects it because that's primarily, the older you are, the longer you've had to damage your blood vessels. So age is related. Genetic, there may be some genetic risk, but it's not nearly as prominent as that seen in coronary artery disease or heart disease. For cigarette smoking, we know that there's a direct relation to it. It is the strongest relation, and it's not a new finding. I mean, this is as far back as 1911, a study showed that people that smoked were 3 times as likely to develop symptoms of peripheral vascular disease. This IC here stands for intermittent claudication, and that's one of the things that you get with peripheral vascular disease. That's cramping of the muscles when you exercise, and we'll talk some more about that a little bit later. But you're 3 times more likely to get that if you're a smoker versus people that have the same risk factors that you have. They may have high blood pressure, cholesterol, diabetes too, but they don't smoke. You're 3 times more likely to develop symptoms from peripheral vascular disease as they are. The association between smoking and the development of peripheral vascular disease is even stronger. It's 2 times more risk associated with smoking and peripheral vascular disease than it is smoking and coronary disease, or disease of the vessels of your heart. In cigarette smokers, the development or the diagnosis of peripheral vascular disease, again, in people in equal risk factors other than smoking, the diagnosis of peripheral vascular disease is made up to a decade sooner. So you develop disease earlier, and the severity of your disease directly correlates with how much you smoke. So somebody that smokes 2 packs a day is going to be much more likely to develop more severe symptoms than somebody that smokes half a pack per day. The good news is that smoky cessation decreases the risk of you developing symptoms from peripheral vascular disease, and you start seeing that risk reduction as early as a year after smoking cessation. As far as the other risk factors goes, diabetes doubles your risk of developing peripheral vascular disease. High blood pressure increases your risk by 2.5 times if you're a man, and up to 4 times the risk if you're a female. Hyperlipidemia, or high cholesterol, high lipid levels. You would think, since most of this plaque is lipid laden, that there's a lot of lipids in it, that the higher that your cholesterol and your lipids are, the more likely you are to develop these plaques. In fact, the evidence is a little bit conflicting on that. What we do know is that the ratio, and what seems to be the most important thing, is the ratio between your total cholesterol and your HDL, or that's the good cholesterol. That ratio is the most important predictor of developing PAD. The higher your HDL, the better. The one thing that we do know, however, about statin medications, anti-lipid medications, is that it reduces the incidence of people developing symptoms, the intermittent claudication, and it's also very important in stabilizing the plaque. So in patients that come to me that have severe peripheral vascular disease, they have carotid disease, even if they have absolutely normal cholesterol levels, I want them on statin medications because I want to stabilize that plaque. I don't want that plaque rupturing and causing an acute problem. I want to stabilize it, and statin medications have been shown to do that. There have been some studies that have shown some reduction in plaque burden, is specifically looking at the carotids with use of statins, even in people that have normal cholesterol levels. Like I said, there is a genetic risk, a clear genetic risk between coronary disease and stroke, up to 1.5 to 2 times the risk if you've had family history, but there hasn't been a clear association genetically with the development of peripheral vascular disease. It seems to be more related to all of those risk factors that we talked about. The presence of peripheral vascular disease and coronary artery disease, though, go hand in hand. A full third of people that have peripheral vascular disease are also going to have coronary disease, and a third of the people that have coronary disease have some peripheral vascular disease. And it's because it's the same disease process. Plaque in the coronary artery is similar to the plaque in the leg or the renal arteries or something like that. So protective factors, number one that's not listed on here is control all your risk factors. If you're a smoker, stop smoking. That is a risk factor that you can directly control, and it's the only one that you can directly control is your smoking. It's very hard to stop smoking. I understand that. Most of my patients that I end up operating on are smokers, so I know how hard it is to stop, but that's the one thing that you can do that will offer you the most protection. Controlling the other risk factors like your blood pressure, your cholesterol levels, diabetes. If you're a diabetic, control your sugar levels, your A1Cs. That's very protective. Some studies have shown that moderate alcohol consumption, usually red wine is usually associated with it. That has to do with the antioxidant effects of those wines. And then obviously regular activity. Some of the patients that we can't operate on because they're too high of a risk, just regular exercise actually makes their symptoms get better even if we haven't opened up any of the blood vessels. So what happens to patients that have PAD or peripheral vascular disease? You would think that this is a rapidly progressive disease, but in fact 75% of the people that have some symptoms of intermittent claudication, the calf cramping that develops because of peripheral vascular disease, 75% of those patients will remain stable or actually get better, and that's usually along with becoming aware that what's going on and then doing things to affect that by risk factor modification. Only 1 to 5% of these patients that have symptoms will end up needing an amputation over 5 years. Unfortunately, a lot of those are diabetics. Diabetics tend to have more distal disease further down the leg, so those vessels in their lower leg and their feet actually become more affected. That, along with neuropathy associated with diabetes, leads to a lot of these amputations. Only 5% of people that have peripheral vascular disease, not 5% of people that have claudication, but 5% of people that have peripheral vascular disease need operative intervention at any point. The cause of death, though, is very clear. If you look at this slide, what it shows is that non-vascular deaths in people that are symptomatic with peripheral vascular disease only accounts for 25% of deaths. So a full 75% of people that die with intermittent claudication are dying because of some problem in their vascular system. Whereas in people that don't smoke that don't have symptomatic peripheral vascular disease, almost half of those people die of things other than vascular disease. So how do we diagnose somebody with peripheral vascular disease? Well, one of the first things, obviously, is something that we've already been touching on is what kind of symptoms do you have? Intermittent claudication is the thing that we see frequently when you have peripheral vascular disease in your legs, and that's simply a supply and demand mismatch. So you get muscular pain in your legs whenever you try to walk or exercise, and it's relieved with rest. And typically patients will be very consistent. So it's not like I can walk to my mailbox today and yesterday I could only walk across the living room. It's typically very consistent. I'll have patients come in and tell me I can walk halfway to my mailbox every morning. I have to stop, wait a few minutes, pain goes away, and then I can walk the rest of the way to my mailbox because it is a consistent, the blockage doesn't come and go. If you have a blockage, it's consistent, it's there. And it's a supply and demand mismatch. So whenever you start to exercise, that muscle needs more oxygen to work, and that oxygen is brought to it by the blood. And if there's a partial blockage, tell people it's like your fuel line. If you have a partial fuel line blockage, that motor's not going to run as well. So you're going to start getting a pain. You stop, you go back to idle, you don't need as much blood flow, the pain goes away. So that's intermittent claudication. The pain that you develop is usually one level below where the problem is. So the aorta is the main artery that comes out of your heart, and it comes down your chest, comes down your abdomen, about the level of the belly button, it splits, and that's where it comes out to your legs. So down to your groin, blood flow, that's called inflow disease. And if you have a problem up here in the aorta or the iliacs, which is what the vessels are called after they split, if you have a problem in those vessels, typically you will have some pain in your buttocks and your thighs when you try to walk. If, however, the blockage is in the outflow vessels or from the groin down, typically between the groin and the knee, then where you're going to develop pain is going to be in the calves. Your thighs and your hips won't be involved because they're getting plenty of blood because the blockage is between your groin and your knee. So it's simple plumbing. So you're going to have problems where you're not getting enough flow. So only a minority of patients that have PAD, I think we talked about that before, only about 5% or so will develop some intermittent claudication. And that correlates with some of the questionnaires that have been given. These were big studies, and it was 3 to 6%. It does increase in men, and it increases in age. So what about the association of age and race? So obviously, this clearly shows that the older we get, the higher the risk of developing symptoms from peripheral vascular disease. Blacks and Hispanics do have a higher incidence than whites. That's probably because blacks and Hispanics have a much higher incidence of both hypertension and diabetes, which are the two of the big risk factors for developing intermittent claudication or peripheral vascular disease, I should say. So in diagnosing peripheral vascular disease, the easiest thing that you can do, and virtually anybody can do this. A nurse that checks you in the clinic can do this. This is done in primary care clinics. You don't have to go to a vascular surgeon to do this. It's to feel for a pulse. We frequently, when we're looking at the periphery, we'll feel our pulses at the groin, behind the knees, and on the feet. On the feet, we feel on the back of the foot and then behind the ankle because there are two vessels that run onto the foot in those locations. It's a good, gauge as to what somebody's blood flow is, but it's not very specific because up to 10% of children don't even have a dorsalis pedis, which is that vessel that runs on the back of your foot. So what I tell people is just because I can't feel it doesn't mean you have peripheral vascular disease, but if I can feel all your pulses very cleanly and that you have strong pulses, most likely you don't. So it's a good negative predictive, not a very good positive prediction. So the first screening type study that we can do that gives us very good data is called the ankle brachial index, and I'll show you this. I'll come back to that one. But what an ankle brachial index is basically we measure the pressure at your ankle and we measure the pressure in your arm, which is the brachial artery, and we compare those two pressures. So we basically get a ratio. We measure the pressure here, measure the pressure there. If the pressure is, say, 100 at the ankle and it's 100 at the arm, the ratio of those two, that's a 1-to-1 ratio. So the ABI, the ankle brachial index, is 1. If, however, say the pressure at the ankle is 90 and the pressure in the arm is 100, then that ratio is 0.9. So that means you've got 90% of the pressure at your ankle that you have at your arm. So somewhere in this system between your heart and your foot or your ankle, you've lost 10% of that pressure. And it's very telling because there's close correlation between the ankle brachial index, that number, and the severity of disease. So if that ratio is less than 0.9, then you usually have some mild to moderate disease. Anything over 0.9, 0.91, that's considered normal. That's a normal range. But if you get less than 0.9, usually around 0.7, 0.8 is when people will start developing those symptoms of intermittent claudication. If it gets even worse and you're getting ratio down to 0.5, where now you only have 50% of the pressure at your ankle that you have in your arm, then those patients are the ones that will start to develop some pain even when they're at rest. So we put a fancy name on that condition. It's called rest pain. That's when you'll start developing those type symptoms. If it gets even lower, say below 0.4, those are the patients that are at risk of losing a limb. They get ulcerations or sores on their feet that won't heal. So we have to go in there and restore some of that blood flow to help that healing process. So the next study that we would do, those two are very easy screening studies that anybody can do. The next one is more complex because it requires somebody that's trained in using a duplex ultrasound. And duplex ultrasound just means we're using regular ultrasound to look at the blood vessel, then we're using Doppler to measure the blood flow through that blood vessel. So if we see something that looks like a tight spot, we can actually look at it with Doppler, and we can measure the flow through there and see how well the flow is going through there and see if it is hemodynamically significant, meaning it's actually limiting the amount of blood flow coming through that blood vessel. So we can tell that with ultrasound, but that requires a registered vascular technician or an RVT, which we have in our clinic, so we're able to do these studies. And while the other studies are good screening studies, they tell you that there's the presence of disease, but it doesn't tell you where it's at, what's going on. We can tell a lot of that, get a lot of that information just by doing a duplex, because we can see, do you have good flow at the groin or do you have good flow at the knee? Where are we losing our flow? The other two studies are a little bit more invasive, and they're similar in ways, but the biggest thing is a CT angiogram. It's less invasive than an angiogram, but a CT angiogram, basically, you get an IV in your arm. You have to get contrast administration though. And you do get radiation exposure because it's an X-ray study. The other thing is that it is diagnostic only. So if I see, okay, there's a blockage there, that's good, I've diagnosed it, I know where it's at, but I can't do anything about it. I've got to do another procedure. And the procedure that I usually do then would be an angiogram, which is what I typically do for diagnosis. Instead of doing the CT angiogram, instead of giving you the radiation and giving you the added radiation and the added contrast, I'll go straight to an angiogram. The angiogram, it is more invasive because we have to access a femoral artery in your groin. We put a sheath in, we shoot contrast or dye, and we can see those blood vessels, and then we can do something about it. At that same time, I can treat the lesions that I see. So it's both diagnostic and therapeutic. So talking about therapy for peripheral vascular disease, what do we do for it? So we'll start at the top, the aortic iliac disease, or inflow disease, as we talked about. So if you have problems there, what do we do? So there's different ways. There's the open method, or the old-fashioned surgical, we cut you open and fix it method, or they're the minimally invasive techniques using wires, catheters, balloons, stents, and things such as that. So with aortic iliac disease, the old way of fixing this is very similar to the way we fix aortic aneurysms in an open fashion. Basically, this is called an aorta bifemoral bypass. We go in here, we actually cut your aorta in half, or we cut a big incision on the front of the aorta and we sew a graft to your aorta. So this is your main pipe. So this is a big operation. And then we run these tails of these grafts down into through your pelvis, down to your legs, and sew it to the femoral arteries. So those are some big operations. They work very well though. 75% of these are still open at 10 years. And we look at angioplasty and stenting. So if we if we balloon this and put a stent in it, it has about a 75 to 80% success rate, probably a little bit higher than that now with some of the newer techniques and newer stents that we have. So up to 80% at 5 years. The good thing with the angioplasty and stent though, it's much less invasive. It's usually an outpatient procedure instead of several days in the intensive care unit and up to a week in the hospital. But the angioplasty and stent, I can repeat that. If you start developing a stenosis in that, I can go back in, and in an hour we can be done fixing that, and you still go home that afternoon. So that's still they're equivalent at this point. So these are just some examples. I know some of these may be hard to see here, but this is an example of a stenosis in the right iliac. So this is like we're looking face on with you. So this is your right side, this is your left side. And this is a tight spot in that iliac artery there. And when we're treating stuff right at that top, we don't want to treat just one side, because if you crack the plaque at the top, you can push it over into the other side and totally block off the other side. So whenever we're doing something right at that split point there, we'll usually do what's called kissing balloons, or if we have to treat both sides, kissing stents, where we put balloons up both sides and inflate them at the same time. This side, the treatment on the right side, that's a bigger balloon. It's made to protect that, or to fix that blockage there. But the one over this side, this is a protective balloon on the left side. This one even shows it more clear. This is a tight blockage. This is probably about 60-70% on both sides. Looks like the left side's a little bit worse. We did the kissing balloons, or kissing stents on this patient, and you see excellent results. I mean, these things just work very well, and they're very well tolerated. If you have some disease that's a little bit further down, it's not right at the crotch, sometimes we can just come over from one side. I call it going up and then going over to fix the other side. And typically when we're working on the right side, we'll access the left groin. When I'm working on the left side, I'll access the right groin. So we actually go up and over. Here there was a tight stenosis here and another one here, and both of those were able to be fixed by placing stents across those. Femoral popliteal disease, so that's the outflow disease. That's the disease that goes from the groin down to the knee. So patients that have that are symptomatic, they would have the claudication in their calves. So the old-fashioned way of doing that, and we still do this on some patients because not every patient are we able to get open using just wires and balloons. If we do this, we're using either your vein from your leg, or we're using a piece of plastic, a plastic tube, to act as a new conduit or a new pipe to bypass the old pipe. So basically your artery has occluded, so we're using something else to go around that. We make incisions above the blockage in the artery, an incision below the blockage in the artery, and then we sew the graft to each end, and now we've basically just given the blood a way to get around that blockage. And again, we still do this not infrequently. So the new way of doing things, or the newer way, it's actually been around for over a decade now, because I did my vascular surgery training in 02, 03, and or 03 to 05. And whenever I was doing my training, we were doing these techniques. They were relatively new at the time, and we've made a bunch of new changes since then that have made it better and even more long-lasting repairs. But when we talk about endovascular, we're talking about angioplasty. Angioplasty just means inflating a balloon to open that lumen back up. Stenting and plaque excision are one of the newer things. We're actually, instead of using a balloon and just pressing the plaque around and sort of redistributing it in that plane underneath that inner layer, we're actually removing some of the plaque, and we're actually take stuff out like this and put it on the back table. So we're actually debulking the plaque. So early on, we started out just doing angioplasties, and you see here, there's a tight stenosis here, put a balloon across it, we got a great result. And a lot of times they look beautiful at the time that you do them. The problem with just doing angioplasty is it doesn't last very long. A lot of times, your 1 year patency rate, or without having to go back in and fix it, is very low if you're just doing a balloon. So that's why we came up with some of these other techniques. There's several different atherectomy devices. The one that I use the most is called a directional atherectomy device, which means I can just turn that device and I can remove plaque on different sides of the blood vessel. So I usually will do all 4 quadrants and make a cut down each side of that lumen to clean it out. This is an example of a femoral artery, a superficial femoral artery that's totally occluded. You can see it comes down here, nice and thick here, and then all of a sudden it ends. All of these smaller vessels, these are called collateral vessels that have dilated up, trying to get blood flow around that blockage. So we have some patients that have total blockages and they have very few symptoms, and their ABI looks actually pretty good, is because that is an old blockage and they have had a long time to develop these collaterals. So your body tries to compensate. It tries to get blood flow around that blockage. So like we had said before, with those ruptured plaques, that causes acute problems, something sudden, and those are the most dangerous issues when you have not chronic disease, but acute onset problems. So this way this orbital device uses, or this directional device is used, this blade actually spins at a high rate of speed, and it actually just carves the plaque in that inner lining of the blood vessel out. So we're actually debulking the plaque. So that's that vessel after we've shaved it out. So it's wide open now, and you see that you don't see nearly all of those collateral vessels that you'd seen before. This is another example. This is again the superficial femoral artery is coming down. This is called the deep femoral. So that's how blood gets around the blockages a lot of times. If the superficial femoral is occluded, all these branches of the deep femoral bring the blood flow around. That's good because it keeps your leg from dying, but it's not good enough. It doesn't give what we call inline flow, a good head of pressure getting down to that lower leg to make the pain go away or to help the wounds heal. So this is an example of that. And again, this is after we've fixed that, we've carved it, we've shaved it out and done a balloon angioplasty on it. Now you see most of the blood is going down here and little of the blood is filling those collaterals now. Just more examples. This is angioplasty and stent, and I will tell you that we use stents in a minority of the cases in the legs. We don't like to use the stents because in your legs, the blood vessels run through a canal in the muscles. There's a lot of torsion and turning of those blood vessels in that muscle canal, and stents don't like to be moved around that much. So while stents work very well up in your pelvis because those stents and those vessels aren't getting twisted, turned, and bent, they are in your leg. So they don't do as well. Sometimes, most of the time, when we use stents in the leg, it's because a flap has developed in there or there's been an injury to the vessel and trying to get it open. So we'll have to put a stent across that to keep that from clotting off. But we do have excellent results with the stents as well. This is just another example. This is that SFA. It's hard to see on here, but you can see us working the wire down. That's how we get through that. We sort of form a loop on the end of the wire, use a little support catheter, and working those two together, working down the leg through that blockage, we're able to get completely through it. Once I get a wire through it, that's my rail on which I can now put all of the other tools that I use to open that vessel up, but I have to have that wire through there that act as a guiding rail to do all of my work. So other than the legs, we do other things. Some of the other two, I'm going to talk about two other arterial issues that we see frequently. Carotid artery stenosis is one of those. That's what we had talked about some a while ago, that if the plaque ruptures, that plaque can send pieces of the plaque or clot to the brain and cause a stroke. Stroke is the second leading cause of death in the world. And in the United States, every 45 seconds, somebody has a stroke. So it is a huge problem in our society, and 70% of those strokes in the United States are ischemic strokes, meaning something has gone up and caused a blockage in a blood vessel, and the carotid artery is the leading cause of that. You can get stuff, plaque or usually thrombus from the heart that goes up, but the vast majority of ischemic strokes are caused by carotid artery stenosis. There are several ways of treating this, and we'll talk about them and why we do one over the other. You can do medical therapy or an open, CEA stands for carotid endarterectomy, that's the open surgical technique, or a carotid artery stent. So who needs to be screened for carotid disease? Number one, one of the things, if you've been to your primary care doctor and he put his stethoscope on your neck and listened to your neck, he was listening for what we call a carotid bruit. So basically that is a swishing sound through the carotid artery. So instead of a nice the thump, he hears a swishing sound. That's a carotid bruit, and that's an indication that you may have carotid stenosis. It doesn't mean that you have carotid stenosis. Some people have carotid bruits and no stenosis. Some people have huge stenosis but no carotid bruit. So, but it is one of the signs that we look for that you may have some carotid disease, and those patients should at least get a carotid ultrasound, and that's how we diagnose most carotid diseases, by ultrasound. The other thing are patients that have any of those risk factors that we talked about. We talked about the big four: smoking, high blood pressure, high cholesterol, diabetes. If you have those types of symptoms, those patients should at least be screened for carotid artery disease. So when do we operate? So there have been big studies done both in Europe and in the United States. There were large studies, and different studies. They looked at patients that had symptomatic disease and patients that had asymptomatic disease. And when we operate on carotids, we are doing it to prevent a stroke. If you have had a stroke, us opening up your carotid is not going to make your stroke better, because you've already suffered the injury. The brain is injured. So it's not going to make your stroke get any better, but it can help prevent you from having another stroke if you've had one, or if you haven't had one, it can prevent you from having a stroke. But all of these studies, and basically, in a nutshell, if you have no symptoms, the studies have shown that up to about 80% medical and surgical therapies are equal. There's no advantage to doing surgery, because medical management is just as good, up to about 80% if you're having no symptoms. If you go over 80%, then we can reduce your risk by about 53% over a 2-year period of having a stroke if we go in there and remove that plaque versus just continuing to try to treat you medically. Medical management basically is an antiplatelet agent like aspirin, 81 milligrams of aspirin every day, so just a baby aspirin every day. Statin medication, so again, we're trying to stabilize that plaque, so that's medical management. And controlling your risk factors. If you're a smoker, stop smoking. So that's medical management. We have different numbers though on symptomatic. If you've had a stroke or you're having TIAs, TIAs is the fancy word for mini strokes. So if you have had symptoms that have come and gone, where you had sudden onset weakness or numbness on just one side of your body, you had drooping of one side of your face, or you lost vision in one eye, looks like a shade pull down that clears up. Not just your vision gets a little bit blurry, but you lose vision in that eye. That's called amaurosis. Those are symptoms of a mini stroke or a stroke, and those patients, if you have stenosis of over 50%, we can significantly reduce your risk of having a full-blown stroke in the next 2 years by removing that plaque. So those are the patients we do endarterectomies on. So an endarterectomy, it is an open operation. It's done under general anesthesia. We make an incision on your neck over the carotid artery. We actually go down here and we control the artery. We clamp the artery off at the top and the bottom. So we've isolated that artery. We make an incision in the artery. Then I use a tiny little device that actually looks like a tiny little spatula. And I just peel that plaque out of there. And generally that plaque comes out as one big chunk. So we clean that out and we irrigate the vessel make sure we've got all the debris out. And then instead of just closing the vessel, if you just close the vessel, you can pinch it and you can actually narrow it down some. So instead of just closing it, we sew a patch on top of that blood vessel. So that's called a patch angioplasty. And the studies have shown that you are much less likely to have a recurrent stenosis or a recurrent narrowing of that blood vessel. It won't come back. It's much less likely to come back if we patch it versus closing it primarily by just sewing it closed. So I patch everybody on mine. There are some risk of doing this procedure. There's about a 1% risk of stroke in doing this procedure, and there's risk of general anesthesia. You can have a heart attack if you have bad coronary disease. So every patient, since this is a known risk of this procedure, every patient that I evaluate for carotid endarterectomy has to go see cardiology and get cardiac clearance. I want them to look at their heart and tell me, I think this guy can handle, or this lady can handle a general anesthesia procedure without having a heart attack. The other thing is there's a lot of little nerves. They're called cranial nerves around the carotid artery. We know they're there. I say little, but they're sizable nerves that we can easily see. So the first thing we do when we get in there, we make a search for all of those nerves. We identify them. We protect them throughout the case. I use what's called EEG monitoring during the case. So basically I have probes on your head and your arms and legs, and we're actually monitoring your brain function. And if I do that, I can usually just clamp this vessel off, and if there's no changes in brain function, I don't have to do anything else other than clean the stuff out and close it up. If, however, we see changes in your brain function, then we do what's called a shunt. We put a small plastic tube that goes around that where we've got the vessel clamped off, and that allows blood to continue running up that side while we're working on the inside of the blood vessel. So we're putting in a little temporary bypass while we're working on the blood vessel. But only about 5% of patients will usually need that if we do EEG monitoring. And this is the kind of stuff that we get out. So it's, like I said, it usually comes out as one big chunk, this is a wonderful operation. It has great patency rates, long-term effectiveness, and it has low risk. As I said, only about a 1% risk of stroke. Carotid stenting, just like everything else, like we're doing in the periphery, when this first came out, it was the rage. Everybody thought this was going to completely replace carotid endarterectomy. However, what we found is that this is the one place in the body that the open procedure is actually better than the endovascular procedure. You actually have a higher risk of stroke doing the carotid stenting than you do by doing the carotid endarterectomy. And that's because we're controlling the vessel above where the disease is when we're doing it open. And if we're doing a stent, we're just pushing a wire up through there. And even in our legs, when we're pushing wires through blockages, virtually every one of those cases has some distal embolization, meaning you're knocking something off of that plaque and it's going downstream. We use a little wire that has a filter on it that actually helps prevent that. But if something breaks off in this vessel, it doesn't go down and block out a little vessel to a muscle down here in your leg. It goes to your brain and causes a stroke. So it's actually has a higher risk of stroke. The advantages are it can be done with no anesthesia or no general anesthesia. It's usually done under local with IV sedation, has a much quicker recovery, and you're less likely to injure nerves because you're not making any incisions around those nerves. So these procedures are indicated only in about 10% of patients, and patients that come in that are a very high risk for general anesthesia, but they need this thing fixed because maybe they're having symptoms, or if it's somebody that has had previous neck irradiation or they've had a carotid endarterectomy done before, that can increase the risk of doing a open procedure, so a stent may be the better option in those patients. So finally, as far as arteries are concerned, we're going to talk about aneurysms, and aneurysms are just dilations or ballooning of a blood vessel, and where we see those most frequently is in that main artery, the aorta. If you have it up here above your diaphragm in your chest, that's called a thoracic aneurysm, and the indication to fix that is if it dilates up over 6 centimeters, and down here in the below the diaphragm, that's called an abdominal aortic aneurysm. We usually see the aneurysm develop right here between the kidney arteries and the split, where the vessel splits. That's where we typically see an abdominal aortic aneurysm, and those we fix at 5.5 centimeters. And we don't fix them when they're smaller because there's risk of doing any procedure we do. And there have been large studies that have looked where is the highest risk of rupture. So that's why we do this, is to prevent this thing from rupturing. And so if you look at the size of the aneurysm and the risk of it rupturing, we know that at 5.5 centimeters in the abdominal aorta, that risk curve takes a steep turn up. So we know that's where the flexion point is. That's where it seems to be the highest risk point or increasing risk point of having a rupture. If an aneurysm ruptures, you have about an 80% mortality rate. So people that rupture outside the hospital, less than half of them make it to the hospital, and the half that make it to the hospital, less than half of them ever leave the hospital. So it's a very deadly disease if you have a ruptured aortic aneurysm. Some famous people have died of that. Lucille Ball died of a ruptured aortic aneurysm, and Albert Einstein actually died of a ruptured abdominal aortic aneurysm. And this is a picture of one. This is 3D CT rendering, and this is the type of study that we get when we're planning on fixing one of these, because it gives us a lot of anatomic information. You can see here the vessel looks relatively normal here, but right above the bifurcation there, it balloons out and gets big. And then again, it's right above the split point. Sometimes this aneurysm can extend down into both of these, one or both of these arteries, but again, that's not a big deal generally. We can fix that when we fix the aneurysm. We already talked about a aortic bifem or aortic bypass as one of the ways that we fix blockages, and that is the old-fashioned way of fixing abdominal aortas. The newer way, the way that we fix the vast majority of aortic aneurysms now, is by putting a stent graft in those. And this graft, if you see this, which I had one to show you, actually looks like a pair of pants with one long leg and one short leg. We put the pants up one side, and then we put the other pants leg up the opposite side to build the graft. So we actually build this graft inside of your blood vessel, and when we get through, it looks like this. So you actually have, now you're basically diverting all your blood flow through this graft instead of putting pressure on the wall of the aneurysm. The aneurysm eventually starts to collapse down around the graft and will actually get well incorporated there. So this is a great operation. This is usually just an overnight stay in the hospital, whereas doing it the way we used to was usually around a week or so in the hospital, 2 or 3 days in the ICU. So that's pretty much it for the arterial side. So we do also do some things on the venous side. That's the blood vessels that bring blood back to the heart. And the thing that we see most frequently is in the legs. It's venous insufficiency, meaning those veins are not getting the blood out of your legs. To understand that, you always tell people a little bit about the anatomy in your legs. I tell people you basically have 2 sets of veins. You have deep veins and superficial veins. Deep veins are those veins that are down in the muscle compartment. They're responsible for getting about 90% of the blood out of your leg. And then you have superficial veins, which are those vessels right up under the skin. People that have bad varicose veins, all of those varicose veins, the definition of a varicose vein is an abnormally dilated superficial vein. So it is actually outside the muscle compartment. And what causes that is a buildup of pressure in those veins. So this is just another picture that shows some of those veins. And people that have problems with big varicosities, the vein that is the usual culprit is the great saphenous vein, which is actually the longest continuous vein in your body. It goes all the way from your foot up the inside of your leg in your groin. It actually dives deep and joins directly to the common femoral vein, which is the deep vein. Right up there in your groin, and so it dumps blood from the superficial down into the deep. So this is just illustrating that there are the deep veins, the superficial, the greater saphenous lies right on the outside of the muscle compartment. Then there's more superficial, what we call tributary veins, and there are connections between those veins. So these veins that connect the superficial to the deep are called perforator veins, and they all have valves in them, because we're fighting gravity. Gravity, it works 24/7. So when we have our legs down in a dependent position, whether we're standing or we're sitting in a chair, sitting at a desk, truck drivers are some of the worst because you have your legs down all the time. That puts pressure on those veins. But if everything works right in your venous system in your legs, blood should only flow from your toes to your groin and from the superficial veins down into the deep veins. And all of these valves in these veins are oriented such that it keeps the blood flowing in that direction. What pumps the blood out of your leg is your calf muscle. It's called the calf vein pump. So every step you take, 3 big veins that run through that muscle compartment get squeezed. That pushes the blood up the leg, and when that happens, the valve opens. When that valve, that allows the blood to go up toward the heart. Between those contractions, when that pressure decreases, those valves will slam shut and keep the blood from just pooling there. What happens in varicose veins or venous reflux, whether it's in the deep or superficial system, is those valves fail. And these valves are very thin. I mean, if you take a vein and you cut it open and flay it open, you can actually see through the valve. They're thin little valves. There's only 2 little leaflets to each valve, so they can get damaged in a variety of ways. But when they get damaged, it allows the blood now to just pool there in place instead of moving the blood out of your leg. So this is a big problem. In the United States, 72% of women, 42% of men by the age of 60 are going to have some varicose veins. So it's a huge problem. It is related to age and gender. The older we get, the more likely you are to have some. Women obviously get them much more frequently than men. Some of that probably due to pregnancies, because the more pregnancies you have, the higher risk you are. Some women develop their varicosities during pregnancy. Sometimes they go away, sometimes they don't. Family history, most of the people that come into us that have severe varicosities have multiple family members that have had varicosities. Obesity is one of the problems, and standing professions. So doctors, teachers, police, and like I said, truck drivers with their feet down, or even if you work in an office all day long and you have your feet down, it allows that blood to pool because you're not actively pumping that blood out. So this just demonstrates how big a problem venous disease is. I mean, we said coronary heart disease is the leading cause of death, and look at how much more prevalent venous disease is than coronary disease. So luckily, venous disease usually doesn't kill us. So when we're talking about abnormal superficial veins, there's a continuum, and this is just different grades of the same disease. All of these vessels are abnormally dilated veins, superficial veins. Telangiectasia is a fancy word for spider veins. Those are usually less than 1 millimeter. Reticular veins a little bit bigger, 1 to 3. If you get bigger, stuff like this, those are varicose. So that's over 3 millimeters. This is in the distribution of that great saphenous running up the middle of your leg there. Some people that have primarily deep vein insufficiency, this is one of the things we see in clinic quite frequently, and I know a lot of the primary care physicians have to deal with this kind of thing, is stasis dermatitis, and people can get actually cellulitis of this. Their skin may become weepy. That generally indicates this is not just a superficial problem, this is a problem in the deep system, because you're having a problem getting blood out of your leg in a much bigger fashion than just varicose veins. That can progress and get even worse in this whitish area here. That's where the pressure is getting so high that it's actually impeding the blood flow to feed that skin. And if that is not treated, it will result in ulceration. So those are venous stasis ulcers. So in the United States, every year, 20 million people are diagnosed with varicose veins. About 6 million will start having some swelling or edema of their leg due to venous insufficiency. 1 million people will start getting these dark discoloration of their legs, or hardening, and their leg will sort of feel hard down there, almost like leathery or woody texture to it. And then 500,000 people will actually develop venous stasis ulcers every year in the United States. So the conservative management for that, which is required before any kind of surgical management can be done, that's a rule of the insurance companies. You got to have at least 3 months of conservative management. But conservative management is elevation and compression. When we say compression, we don't mean wearing really good socks. We mean wearing graduated compression stockings. Graduated compression stockings are actually tighter around the foot and ankle than they are the calf and thigh. So it creates a pressure gradient to push the blood up and out of your leg. So it depressurizes your leg. It does help with some of the pain that you have from venous congestion. The problem is that it does nothing to treat the underlying pathology. Okay? Unfortunately, for deep vein insufficiency, it's the only tool we have. You can't operate on the deep system. Those procedures are fraught with numerous complications, and they have about an 80% failure rate. So virtually nobody operates on the deep venous system. So the primary treatment is compression and elevation for the superficial system, or for the deep system, but the superficial system we can treat. And that's where vein stripping comes in. That's the old way. So we talked about the saphenous vein being the longest vein in your body and the one that causes most of the problems with varicose veins. So used to, this was the way we did it. We make an incision in your groin, incision at your knee. We put a little device through that vein, and we just rip it out. That's vein stripping. So as it sounds, it was painful. It was done under general anesthesia in the operating room and required a 1 to 2 day stay in the hospital. And sometimes you grew a new vein there. The damage caused what's called angiogenesis and the development of a new vein. So sometimes it failed. That's not the way, luckily, that we do it nowadays. I haven't done a saphenous vein stripping in over 15 years. And the way we do it now is we use a catheter, just like we use catheters in the arteries to open things. In the vein, we're using a catheter to close the bad veins. And basically the one that I use, there are two predominant ways of doing this, is either using radio frequency energy to heat the vein or laser energy to heat the vein. Radio frequency, I prefer less pain, less bruising. There's several advantages I feel to radio frequency. Both of them work very well, but this is the one that I use primarily as a radio frequency. And this tip of the catheter here, this gold piece that's 7 centimeters long, that's actually a heat element. And that's how it works. It's basically cauterizing the vein from the inside. So this is a clinic-based procedure. We do it in the clinic. It takes about 30 minutes in the clinic. You walk in, you walk out. So we access the vein right around the knee area, just like starting an IV. We thread this catheter up the vein under ultrasound guidance, so we're watching it go. We go all the way up to that connection point and come a little bit off of it, a couple of centimeters down from that connection point, and inject fluid around the vein the whole distance. And that fluid has lidocaine in it, so it numbs everything up. It also compresses the vein onto the catheter, so there's good connection between the vein and the catheter. And then we turn the catheter on. That catheter heats up to 120 degrees Celsius. That's over 200 degrees Fahrenheit. Luckily, you don't feel it. It actually cauterizes the vein. It only has to heat it up for 20 seconds, and it'll heat 7 centimeters at a second. So 7 centimeters for 20 seconds, 20 seconds, 20 seconds. We just walk it down your leg. Once we actually turn the catheter on and start treatment, 2 to 3 minutes later, we're done. Okay, so it works very good. And like I said, this is an outpatient procedure that you walk in to our clinic, put your compression stocking on after we finish, and you walk out. And this is an example. I mean, this is obviously a huge saphenous vein, and this is just 1 week post-treatment. Now, we close the saphenous vein like this, but it leaves all these little varicose veins. These varicose veins aren't going to go back to normal. But what it does is it gets the pressure out of these veins, so it makes it easier for us to treat those. So we like the venous closure because it relieves your symptoms almost immediately. People say they can tell almost immediately, much less pressure in their legs. You can return to your normal activities 1 to 2 days. When I was active duty in the Air Force, I would have people resuming physical training, PT, within a week. Lifting weights, running, whatever they needed to do within a week. It is an outpatient procedure. This says local or general. I never do general anesthesia for this. It's done in the clinic. You have great results. And luckily, it is now covered by virtually all insurance companies. Other procedures that we do for the veins, like I said, the other veins aren't going to go back to normal size, but if we get the pressure out, it's easier to close them minimally invasive by injecting a chemical into it. That's called sclerotherapy. And sclerotherapy, basically, it just uses a chemical to damage the vein. So instead of using heat to damage the vein, we're using a chemical. If the veins are larger, we'll actually mix that chemical, which in the United States, the 2 scleroses that are approved are detergents. We'll mix those with air, make a foam. Under ultrasound guidance, we'll access the vein with a needle and inject that chemical directly into the blood vessel. And what it does is it causes damage, causes the vessel to thrombose. When it thromboses, it'll then turn into a fibrous cord or a scar, and then it will close down. And your body dissolves that scar tissue away eventually, and the vessel is closed. Finally, phlebectomy is just a removal of the vein. This is very uncommon that we have to do that, but sometimes you do have to make an incision to take those veins out. But that's pretty much the way we treat varicose veins. I know there was a lot of stuff we covered, but I look forward to serving the Cullman community, and if you have any problems, just contact our office and we'll get you in to see you ASAP. Thanks a lot.